Hello, everyone. Welcome to this month's NY Cannabis Grand Rounds, dedicated to advancing knowledge of cannabis in the healthcare. My name is Sang Choi. I am a pharmacist and a research scientist on the scientific programs and research team, and your moderator for today. Today, we are so happy to host Dr. Jun Chen, who is our new Chief Medical Officer, who will present cannabis in the care of children with juvenile idiopathic arthritis and what clinicians should know for Juvenile Arthritis Awareness Month. But before I introduce Dr. Chen, I will read a brief disclaimer. The Office of Cannabis Management makes no claims, promises, or guarantees about the accuracy, completeness, or adequacy of the content of this video live stream event, and expressly disclaims any and all liability of the content and for errors or omissions in the content of this video live stream event. This video live stream event is for informational purposes and convenience of the public only and does not constitute endorsement, recommendation, professional advice, or favoring by the Office of Cannabis Management. The content of this video live stream event is based on information available at the time of recording and is subject to change. So today I am very excited to introduce today's speaker. Not just because of her expertise, but because she's a colleague I've worked alongside for nearly 10 years, caring for patients and navigating complex cases together. Dr. Jun Chen is an integrative medicine physician and nationally recognized expert in cannabis therapeutics, with over 2 decades of experience bridging holistic care, public health, and policy. She's previously served as vice chair of the New York State Cannabis Advisory Board, and we're proud now to have her as our new Chief Medical Officer at the New York State Office of Cannabis Management. Dr. Chen has also been a driving force in cannabis research, publishing real-world studies on patient outcomes, healthcare utilization, and integrative care models. Her work has helped shape clinical protocols and public health guidance around cannabis use. But beyond all of that, Dr. Chen brings a powerful personal story to her work. She was diagnosed with juvenile arthritis, ankylosing spondylitis, as a teenager and has lived with chronic pain ever since. As a daughter of immigrant parents, she knows firsthand what it's like to navigate the healthcare system while confronting stigma and limited access. She's the author of Cannabis and CBD for Health and Wellness, teaches cannabis science at NYU and Syracuse University, and has trained thousands of providers nationwide. Please join me in welcoming Dr. Jun Chen. Welcome, Dr. Jun Chen.
Thanks so much, Sang. Thank you. Thank you so much for that warm introduction and for all the years of collaboration. I'm truly honored to be here today and to be appointed OCM's new Chief Medical Officer. I'm also a Bronx native, and I would say stepping into this role feels both a professional milestone and deeply like a personal homecoming. It's a privilege to help shape a public health framework that centers on equity access and evidence-based care right here in the state that raised me. So as Sang mentioned, for the past 20 years, I have focused on integrative approaches to chronic illness, particularly for medically underserved populations. But before that, I was a teen. I was a teen living with AS, ankylosing spondylitis, which is a progressive form of juvenile arthritis. And I spent years, just so many years navigating the healthcare system, alongside my parents, facing stigma, uncertainty, and pain. And that experience is what drove me to become a physician. I wanted to sit on the other side of the exam table, not just with clinical knowledge, but with empathy and shared experience. And that's why I want to start by acknowledging you, our healthcare providers. You are the first trusted voice that patients and families turn to in moments of confusion or crisis. So your guidance matters. Your ability to ask the hard questions, sit with discomfort, and walk beside your patients, especially when they're considering therapies like medical cannabis. And this can make all the difference. So I want to say, this is not just a clinical topic, right? It's about a partnership. And our job is not to have all the answers. It's really to stay open, to stay informed, and to stay human in our care. So I Thank you so much for being here today. Let's dive into this important conversation with science, compassion, and curiosity leading the way. So let's see here. So I want to begin today with a story, actually, two stories. Two 15-year-olds in New York, both diagnosed with juvenile idiopathic arthritis at the age of 12, but their journeys couldn't be more different. Luis lives in the Bronx. He's Latino, son of immigrant parents. His mom works in a restaurant and his dad in a car mechanic shop. Now, his JIA symptoms started in his knees and in his wrists. He missed a lot of school. He struggled to sleep. He fell behind in class. His doctors prescribed NSAIDs, of course, and then steroids, but no one ever asked about the toll that it took on his mental health and his social life and his sleep. So one day his friend offered him a cannabis vape and said, it'll help you sleep. Luis tried it for the first time, and for the first time in months and months and months, he got a full night's rest. But without guidance and support, cannabis use quickly became daily, and then multiple times a day. And then his tolerance grew, and so did his overuse. He stopped turning in homework. He started skipping class. His parents, already overwhelmed and working long hours, found the vape pen and panicked. They grounded him. They accused him of being a drug addict, and they didn't understand that this wasn't about rebellion. It was about relief. Now we have another teenager, Avi. Avi lives in Long Island. His parents are highly educated. His dad's a professor. His mom is home full time. And when he was diagnosed, they rallied. They booked PT, acupuncture, massage therapy. They even explored dietary changes. After reading about CBD in a clinical journal, they consulted a physician friend, carefully added it to Avi's care plan, and his sleep improved, his pain lessened. He felt supported every step of the way. And more importantly, his parents made sure that he understood the risks of high THC cannabis, how to avoid overuse, how to tackle his symptoms, how to ask for help. So neither Luis nor Avi had physicians who endorsed cannabis, who supported cannabis, who can help him through his journey. But Avi's parents had the resources, right? The resources to ask the right questions, seek second opinions, manage risk. But Luis didn't. He was alone. He was self-medicating, trying to manage chronic illness with no roadmap and paying the price. And that's the heart of today's conversation. Access, disparity. It's not just about medicine. It's about who gets the education, the guidance, the safety net, and who gets to figure it out alone. So JIA, juvenile idiopathic arthritis, is the most common form of childhood arthritis. And despite how widespread it is, it remains under-recognized and frequently misunderstood. It's not simply a smaller or milder version of adult rheumatoid arthritis. JIA is a complex autoimmune condition. It disrupts a child's immune system, causing it to mistakenly attack the body's own joints and tissues and even organs sometimes. It's diagnosed in children under the age of 16 and can present at any point during their developmental years. Some kids are diagnosed as toddlers, others not until their teens. So depending on the study, the prevalence can range from as low as 3.8 to as high as 400 cases per 100,000 children, reflecting high differences in diagnostic criteria, access to care, and perhaps even environmental triggers. So the hallmark symptoms, we're looking at joint swelling, morning stiffness, fatigue, poor sleep. But these clinical terms often fail to capture the lived-in experience. Imagine being 7 years old, struggling to zip up your jacket, right? Because your fingers won't bend, or waking up each morning so stiff that getting out of bed feels like climbing a mountain. One patient I cared for told me that her knees felt like they were glued shut until lunchtime. And that's what we're talking about. So standard treatment usually begins with NSAIDs, followed by corticosteroids, methotrexate, sometimes biologics, right? Injections that target specific inflammatory pathways. And these meds can be life-saving, but they don't work for everyone. They often come with a cost. You have immune suppression, sometimes nausea, growth delays, mood swings, for example. So really, it's no surprise then that many families, especially those facing refractory or relapsing disease, they start to look, beyond that traditional toolbox. Now, not because they distrust medicine, but because they're desperate for relief. That's when questions about integrative therapies start coming up, including cannabis, CBD, like that starts to surface. Not a cure-all, but one with more potential tool to reduce pain and ease inflammation and really restore a sense of normalcy to a child's life. So when we talk about cannabis in this context, we're not talking about lifestyle choices. We're talking about quality of care in children who are missing school, missing milestones, and missing out on being a kid. So it's not a single disease. There's a spectrum of disorders, each with its own patterns and symptoms and progression. That's why it's so important to look beyond that general label of JIA and understand the different subtypes, because they vary widely in how they affect the children's body, their prognosis, and even their treatment response. So for example, oligoarticular, most common, it affects fewer than 5 joints, often starting in the knees or the ankles. It might start off mild, but it carries a significant risk of eye inflammation, which can silently damage vision if not monitored. There's polyarticular, which involves 5 or more joints, can resemble adult RA, often attacking those small joints in the hands and feet, causing symmetrical swelling and stiffness. And then you have systemic, and this is perhaps the most dramatic in presentation. It involves not just the joints, but then you have these other symptoms. You have fevers, you have rashes, swollen lymph nodes, inflammation of internal organs. And these children often look acutely ill, and diagnosis can take time, especially when symptoms mimic infection or even leukemia. And you have other ones which cause pain where tendons and ligaments attach to bones. They're often mistaken for growing pains, right? So then you have a psoriatic one, which combines joint pain and skin lesions of psoriasis. Some of these kids will develop sausage digits and nail pitting. But regardless of the subtype, there is this through line on how this disease manifests in a young person's life. You have joint stiffness, hard to get out of bed, hard to climb downstairs. You have this persistent fatigue. It affects focus and motivation. Patients always tell me, like, it feels like I'm walking through mud, or my brain feels like it's like molasses, right? It really has this effect on focus. And then you have flare-ups without warning, disrupting the normal routines. And then there's this emotional exhaustion from chronic pain, missed school, and just feeling different from their friends. Children, with JIA might stop participating in gym or team sports. And then they fear feeling judged because they don't want to draw attention to their limitations. Social withdrawal is very common, so is anxiety, especially when traditional treatments include steroids that affect mood and weight and body image. And then for parents, there's a unique kind of heartbreak. It's watching your little boy, your little girl, your little kid suffer, while navigating this healthcare system that sometimes feels like super reactive rather than supportive. And that's why a lot of families begin exploring complementary options. And again, I said this earlier, not out of distrust of conventional medicine, but really out of deep desire to fill the gaps, right, that traditional treatments don't always address. So this is often where we get that question, well, what do you think about cannabis? And I always say, well, cannabis is not a replacement, but it's a potential ally for managing this unrelented pain, these sleepless nights, these flare-ups, some of the anxiety that conventional medicines don't fully relieve. Parents aren't looking for a miracle, but they do come looking for more tools in the toolbox, especially ones that might help their child reclaim even a small piece of their childhood that's lost to inflammation.
Yeah. So Dr. Chin, I do have a question for you. So when conventional treatments fall short, introduce new side effects, families often feel stuck. So what emotional landscape are they navigating when they begin to ask about cannabis?
That's a great question, saying it's rarely a rebellious move. It's a desperate one. Parents are exhausted. The kids are super frustrated. Families are doing the best that they can to manage these flares, the fatigue and the fear. And what I've seen again and again and again is that they're not seeking cannabis as a replacement. They're really looking for options that offer relief without compounding the problem. And let's talk about this long-term effects of JIA. One of the persistent myths about JIA is that children simply grow out of it. And while some children do go into remission, either spontaneously or with the help of early treatment, the truth is far more sobering. Up to 50% of children with JIA continue to experience symptoms well into adulthood. Up to 50%. That's heartbreaking. This means half the kids will carry their disease into their 20s, into their 30s and beyond, often with complications that are much, much more serious over time. Think chronic joint inflammation can lead to permanent damage. These joint deformities, early onset osteoarthritis, maybe in their 20s, at an age where most peers are just starting their active careers. Other complications accumulate slowly and quietly. Example, like long-term corticosteroids that's needed to manage the flare-ups. You can see bone thinning, growth suppression, even avascular necrosis where bone tissue dies from the lack of blood flow. And for women, young women, meds like methotrexate can have implications on fertility. So that requires careful planning. And in some cases, delaying in family building. So that's something to think about. And then there's inflammation in the eye. That can seem minor at first, but it carries a real risk of vision loss. So if you don't get that early, you don't catch that early and manage that aggressively, that flare can, be independent of these joint symptoms. And often it goes unnoticed until there's irreversible damage. So pediatric rheumatology, highly specialized field. Many young adults, age out of their care teams without this clear roadmap. So they may struggle to find adult rheumatologists who understand the nuances of their disease. And then there's some, like I talk about underserved communities, some lose their insurance coverage. They lose their insurance coverage maybe during college or shifting careers early. So something that was once closely monitored, as through your pediatric rheumatologist, sometimes, gets crazy in a maze of self-managed appointments and referrals and medication approvals. So we have this transition period, what we call the transfer of care. And this is one of the most vulnerable times for patients. It's when medical adherence drops. You have this like difficulty following up with your PCP or your specialist, and then you have mental health challenges, right? That you see that start to peak. And really, you have these young adults, they're expected to suddenly manage this chronic disease on their own, with little support or preparation. That's why it's really important to treat JIA not as a temporary pediatric condition, but think about it as a lifelong inflammatory disease, something that requires a very comprehensible, sustainable approach to care. So let's talk about some pain management gaps. For families navigating the daily realities, pain is not just a symptom, it's this constant companion, right? It shapes how the child sleeps, how they learn, how they interact with their peers. So when pain is unrelenting, you have this emotional dysregulation. You have poor concentration, irritability, and depression. And from an academic perspective, right, these kids miss school, right? You have flare-ups, you have medical appointments, they're not physically present, right? They have this cognitive fog, like I talked to you about. And over time, this will erode in self-esteem and really enforce this social isolation. So for caregivers, it's a very overwhelming task, right? This burden is very deep. It's not just physical. It's not just exhausting. It's emotional. It's logistical. It's financial. So when you have these conventional therapies like NSAIDs and steroids or biologics that don't relieve the pain, you're thinking about ways to add, complementary and integrative approaches to the picture, right? So this is when we start to think about, how rigorous, how rigorous do we approach cannabis care in pediatric care, right? What does the science tell us about anti-inflammatory effects? What are the pharmacokinetics in children? What are the long-term neurodevelopmental impacts? Where are the gaps in research that must be filled before we can responsibly recommend its use? So although cannabis may hold promise, but promise without proper guardrails, especially for pediatric population, is a risk, right? The ethical imperative here is to move very slowly, very thoughtfully, and very transparently to build guidelines that are rooted in evidence and not anecdotes. A lot of these families go on Facebook groups and go on forums and they're trying to figure out, what cannabis formulations to give their child, and maybe they're home growing and it's important to engage these families without judgment, right? Because they're just looking for another tool in their toolbox. And to never forget that as clinicians, our first duty is to protect and empower the children in our care. So yes, this conversation matters, not because cannabis is the answer, but because the families really do deserve honest and compassionate and clinically sound answers, right? You don't want them to walk out of your office losing trust and trying to figure out things on their own on a social media platform, right? As clinicians, we have to be ready to guide and not ignore these choices.
So Dr. Chen, what would you say in your experience, the stigma, whether cultural, clinical, or legal, impact how openly families talk about trying cannabis or even asking about it?
Absolutely. Some families are terrified that they'll be judged by their child's doctor, or their child's school, or even other parents, right? Their peers. Others come from different cultural backgrounds where cannabis is deeply stigmatized. And when that shame intersects with the vulnerability of parenting a sick child, it often just leads to silence. That's why for clinicians, we need to create the safe, judgment-free zone for these conversations. So I'll talk about what the evidence says. What does this evidence say when it comes to cannabis and juvenile arthritis? Well, let's just start with what we know. In a caregiver survey focused on children with JIA, nearly half the respondents who had tried CBD reported meaningful improvements in their child's symptoms, especially in these areas: sleep quality, emotional regulation, and chronic pain. So, as I went on and on in the beginning, these are not trivial gains, right? So for a child who hasn't slept through the night in weeks due to joint stiffness, for a teenager struggling to attend school because of persistent fatigue, these modest improvements in sleep or pain can feel like a transformation. But anecdotes and survey responses, while important, is not the same as clinical trials. So let's look at the mechanisms. Cannabinoids like CBD and THC interact with the body's endocannabinoid system, right? This complex cell signaling network that helps regulate inflammation, immune function, pain perception, and in particular, they bind to the CB1 and CB2 receptors, which are found in the central nervous system and on our immune system and our immune cells. And what's especially relevant to JIA is that cannabinoids have been shown to downregulate these pro-inflammatory cytokines. So we're looking at IL-6, interleukin-6, IL-8. Like, these are the key drivers of joint damage and systemic inflammation in autoimmune arthritis. So CBD may also inhibit the release of matrix metalloproteinases. So these are these enzymes that contribute to that joint degradation over time. So in vitro studies, so these are studies done in cell cultures, CBD has been shown to reduce the inflammatory markers in the synovial fibroblasts. So these are the very cells that line the joints that promote that chronic inflammation and arthritis. In animal models, cannabinoids have demonstrated pain reduction, improved joint mobility, decreased inflammatory signaling. And then this is critical. The majority of that research has been conducted in either adult humans or animal models. So while in many cases, extrapolating from adult data to pediatric care, like, we have to watch out for that. That's a dangerous leap without, adequate safeguards, because children are not smaller adults. Their metabolism, their brain development, their immune responses, fundamentally different. And that's particularly important when we're introducing, cannabinoids. There's also a lack of high quality randomized control trials, right? We don't have these RCTs in pediatric populations. So we don't yet have standardized dosing. We don't have long-term safety data and neurodevelopment. And while early reports are promising, we don't fully understand how cannabinoids might impact the developing immune system, or with those other medications that are commonly used, like the methotrexate and biologics. So what does this mean? What does this mean for clinicians and researchers? What it means is that we must hold two truths at once. There's real promise in the pharmacology of cannabinoids for autoimmune and inflammatory disease, but at the same time, there are gaps. There are gaps in pediatric specific evidence, and it's our ethical obligation to fill in those gaps moving forward with widespread clinical recommendations. So let's take a closer look at specific symptoms that cannabis-based medicine might help. So keep in mind that these are potential effects. They're not guaranteed outcomes. First, pain. Pain is not only caused by inflammation. It's driven by that central and peripheral sensitization. So over time, the nervous system becomes more reactive to pain signals. It amplifies the child's discomfort, even in the absence of active swelling. Cannabinoids like CBD and THC may help interrupt this pain signaling through those CB1, CB2 receptors. They reduce production of inflammatory molecules. They modulate the neurotransmitters like glutamate and serotonin that are involved in pain reception. So what this can mean in practice is, clinically, I will see less morning stiffness. The kids will say, I have improved mobility. I feel like I can get up in the morning and get it and, sort of bounce out of bed a little bit faster. My knees don't feel glued shut until lunchtime, right? There's a greater ease with daily activities, usually with like walking and climbing stairs, or even like writing. When they're writing in school, they feel like there's a little more mobility in their joints. And then, for some patients, I would say it's not eliminating the pain altogether, but it really just turns down the volume to make life feel livable again. And then we have sleep, right? We underestimate the profound sleep effects that sleep affects every other aspect of health. So kids with JIA frequently struggle with sleepless nights. They have joint discomfort, they have side effects from the meds like, steroids. And then, of course, if you have poor sleep, if you can't sleep, you're going to have worsened pain. You're going to have fatigue and irritability, right? Impaired concentration during the day. So studies in adults with chronic pain and autoimmune conditions have shown that cannabinoid therapy, especially with balanced formulations or low THC, might have improved sleep quality and extend the actual, sleep time. It reduces those nighttime awakenings. So for kids, even modest improvement in sleep will have this domino effect. Better mood, better sleep, better mood, more consistent with school attendance, improved family dynamics. So then you have anxiety. Kids, living with this chronic disease, it takes a significant psychological toll. Kids often experience worry about flare-ups, body image, performance anxiety at school, and just the fear of being different. CBD in particular has shown to be a great anxiolytic. It reduces anxiety in preclinical and early human studies. It appears to work by interacting with serotonin receptors in the brain, reducing that hyperactivation in the amygdala, that brain's fear center. Some patients report subtle but meaningful sense of like calm. They'll say, I feel like I did yoga, or I feel like I had a good run. Like I just went out and exercised. Like I feel this better emotional regulation. And that I see when patients use a CBD, without the sedation or blunting effects that you have with THC. And then lastly, appetite, fatigue, and nausea. THC, and I'll say this, with a caveat, because you want to be careful in kids. THC is well known for its ability to stimulate appetite, right? And this can be a benefit for kids who have extreme weight loss, like just can't put on weight. They're all bones. Maybe they have reduced hunger because of the disease activity or medication side effects. THC also has anti-nausea effects, right? So it can be helpful for patients on methotrexate or certain biologics that, that affect the gut. But we do want to be careful with THC and pediatric use. Some studies also suggest that cannabinoids may reduce fatigue as well. And I mentioned that before. This area is still underexplored in pediatrics. Like if I go through research and the data, I don't find a lot of data under fatigue, but this is anecdotally reported. So none of these outcomes are universal. I've seen it work for some kids and I've seen it not work for others. The response to cannabis is influenced by their age and their developmental stage. I would say dosage and route of administration. The THC and CBD ratio is super important as well. And then any underlying physiology and medications. And then you have psychological factors that you have to take into account as well, if there's any trauma or mood disorders. So that's why any consideration of cannabis in juvenile arthritis care must be deeply individualized. There is cautious optimism here. There's a real potential to support symptom relief, but it must be pursued in the lens of data, in the lens of safety, and in the lens of personalized care planning.
Yeah, Dr. Chen, I agree with you. So you've mentioned that cannabis is often seen as a natural option. So what are some of the most persistent myths or misunderstandings you encounter in those early conversations with families?
I think a big one is that CBD works instantly, like a rescue medication. It doesn't. It needs consistency and monitoring. A nut, it's like natural doesn't mean risk-free, which, isn't true either. It's plant-based, but still pharmacologically active, right? We have to guide with nuance. We really have to make sure that we're acknowledging the potential while setting realistic expectations with family. That's a great question. Let's talk about this pediatric use survey. In a recent caregiver survey focused on pediatric patients with JIA, only 7% of families reported current use of CBD products for their child. So, do you hear me now? Sorry about that. I got cut off for some reason. So again, this survey, I have to let me pull up my slides again. Where are we on? Slide survey. Here we go. So on this survey, 7% of families reported use of CBD products for their child. And that's not a lot. It's a small number, but here's a more telling statistic. Over 50% of caregivers say they were seriously considering CBD as part of their child's symptom management. So there's this gap between interest and action, right? And that's revealing, right? It reflects that there's growing demand for integrative options, but there's also a lack of confidence on how to proceed safely. So among those who had already introduced CBD into their child's care, the most common formats were tinctures, gummies, and topical creams. But here's where the alarm bells start to ring. The majority of these caregivers, no clear guidance on dosing. Many didn't know the milligrams per serving. They didn't know the concentration of the product or even the difference between form factors. Fewer, they didn't even talk to their pediatrician about it or their rheumatologist or any clinician. Most of them source their information from social media, parent forums, anecdotal stories, on Facebook. And that's not inherently reckless, but it's a reflection of the information vacuum that we've created, right? When clinical providers are not willing or prepared to have evidence-informed conversations about cannabis, families are left to navigate the space without a compass. So this becomes a call to action for our providers. We need to show up in this conversation, not as gatekeepers, but as guides. Because if we don't offer scientifically grounded counsel on cannabis, families will continue to rely on the internet. And that's where misinformation thrives. Let's remember, like, parents are already asking these questions. Our job is to meet them with curiosity, clarity, and care. So let's talk about the safety and side effects. Let's start with CBD, which is currently the most commonly explored cannabinoid in pediatric populations. In clinical trials, mostly for pediatric epilepsy, like a Dravet or Lennox-Gastaut, CBD has been shown to be generally well tolerated, even in children. That said, it's not entirely benign. You can have certain side effects. Some kids will say they have fatigue or sedation, especially with higher doses. You might actually see like appetite suppression or weight loss in some children. That's rare, but you do see it. So that's been reported. And then in rare cases as well, you'll see elevated liver enzymes, especially if you're taking it alongside medications like valproic acid or methotrexate. So when you're seeing your pediatric rheumatologist anyway, they're doing blood work and they're checking out your liver enzymes. But I do want to just caution you, when you're adding CBD, you just want to take a closer look at that. You want to make sure you have regular liver functioning monitoring and coordination with the child's prescribing specialist. We can't treat it like a supplement from the health food store. Again, it's pharmacologically active compound that interacts with those liver enzymes, potentially altering metabolism of other medications. So with THC, far more controversial in pediatric use, and for good reason. THC is the primary intoxicating compound found in cannabis. So in developing brains, it's associated with a range of neurodevelopmental risks. It can include impairment in working memory and attention span, disruption in emotional regulation and executive function, and with frequent or high use, you might see increased risk of mood disorders, including depression and psychosis, particularly in genetically vulnerable individuals. Okay. THC also does carry a risk of overuse and dependency, especially in teens. Studies suggest that up to 9% of those who use cannabis overall and closer to 17% of those who start before the age of 18 may develop a cannabis use disorder. So these are not abstract risks. They affect school performance and social development, long-term cognitive capacity. So in children with chronic illness who are already dealing with this emotional stress, this social isolation, these risks can be amplified. So another complicating factor is potency. I always like to talk in milligrams instead of potency because everyone reacts to THC differently, but THC levels in cannabis products today are dramatically higher than in past decades. In the 1990s, if you look at flower, THC flower, cannabis flower, the products contain 3 to 5% THC. Today, you might see concentrates and dabs and vapes that reach 80 to 90% THC. So those milligrams are quite high. A lot of the edibles also have a very powerful dose in just one square or one gummy. So we really need to be careful when we counsel patients and their families. So in short, where does this leave us? CBD, I would say, is a reasonable consideration for symptom support, but still must be carefully selected, dosed, and monitored. THC use in children should be considered only under exceptional circumstances, really weighing the pros and the cons. Look at, how disrupted their life are, how much are they in pain? What is their capacity at this point? And how little THC will you add? When all the other options have been exhausted and under direct supervision of a clinician experienced in cannabis medicine, that's when you can bring in THC. I do want to note that many families mistakenly assume that because something is labeled natural, it must be safe, but naturally does not mean inert, right? Cannabis is a powerful therapeutic agent. And like all agents, we need to really weigh the pros and the cons. So we want to make sure that we take a full med history. Sang has always been great at this, right? Taking a full med history, making sure to list everything you're taking, including, vitamins and supplements, reviewing any cannabis use with transparency and a non-judgmental way, and then making sure that any decision we make is grounded in the best available science.
So Dr. Chin, you mentioned that CBD and THC have distinct effects. So when parents feel overwhelmed, how do you break down the difference in a way that makes sense to them, feel more in control and not confused? It can get confusing and very technical and sciencey. So how do you do it?
It does. And it might take like 2 or 3 visits before the families truly grasp what's going on. But I often say that CBD is the calm without the high. THC is where things get more complex. We do talk about ratios of THC to CBD. We talk about delivery methods. So that there's guidance and care, and it's not guesswork.
Right.
Okay, so let's do that. Let's moving on. So when we talk about cannabis and safety in young people, there's one area that we always talk about is brain development, right? The adolescent brain is a masterpiece in progress. It's not fully formed at 13 or 16 or 21. I can attest to that. I have 2 teenagers, and that brain is a masterpiece. The prefrontal cortex is responsible for decision-making, planning, emotional regulation, and impulse control, and it doesn't reach full maturity until the mid-20s. And this is the region that tells us how to weigh risks, how to manage frustration, consider long-term consequences. So this is one of the brain regions most vulnerable to disruption from external substances, including THC. So in other words, THC doesn't affect how a teen feels at the moment. It can actually alter the architecture of how they think and function long term. I would bring your attention to our neuroscientist, Dr. Yasmin Hurd. She's the director of the Addiction Institute at Mount Sinai, and she's led groundbreaking research in this area. Her studies, both in animal models and human brain imaging, has shown that early exposure to THC can have long-lasting changes in brain chemistry, connectivity, and behavior. In rodents, adolescent THC use alters gene expression in these areas tied to mood regulation and social behavior, and those changes persisted into adulthood. All right, so there's also emerging evidence that these effects might be passed to future generations through epigenetic mechanisms. So that's interesting research out there, this altering stress response, this dopamine sensitivity in offspring of exposed animals. So in humans, these brain imaging studies, they have found teens who use cannabis regularly show a reduced volume and connectivity again, in this prefrontal cortex. So the potency issue can't be overstated. The milligram issue, you want to make sure you're careful, especially with unregulated markets. You want to make sure that you're telling the families to use regulated cannabis products. And with the unregulated market, with intoxicating hemp, with stuff that you're buying online at a smoke shop or a bodega, like it's just not tested, and we don't know what's in them. So we really need to be careful. But that doesn't mean we should panic, right? I will still want to say all this, that we still want to proceed with care. We don't want to panic, right? If THC is being considered in a pediatric context, for example, like the kid has intractable pain, the kid has severe nausea, losing tremendous amount of weight, or palliative care, right? Minimally dosage THC, used only when necessary, delivered with medical supervision, monitoring, clear treatment goals. Educate the families, what's actually in the product. Parents don't realize that even over-the-counter CBD may contain trace amounts of THC. Look at lab testing, product sourcing, product labeling. Make sure you have, child-proof bottles as well. Make sure there's safe storage. So we want to take into account all of that when we're talking with patients in the clinical setting. So let's talk about how cannabis reduces pain and inflammation. We discussed this earlier, but I'll review it here. The ECS, we don't learn about it in med school. Complex signaling system, receptors, enzymes, you have endogenous cannabinoids. So all of this plays a role in pain, immune response, inflammation, and sleep. You have the two primary receptors, CB1 and CB2. CB1 receptors, you see it in the brain, the spinal cord. That's where everything is influenced with pain and stress response and mood. You have CB2 receptors, that's found throughout the immune system. So that's where you have those inflamed joint tissues. You'll find those CB2 receptors, especially in people with RA and JIA. And then with this inflammatory arthritis, you have this immune dysregulation. So you have this overproduction of inflammatory mediators. Right? You're looking at the cytokines like TNF alpha, IL-6. Right? These cytokines are not only causing joint swelling and pain, but they contribute to that long-term cartilage and bone damage that I talked about earlier. So when you have CBD and THC binding to these receptors, they downregulate the immune cells like macrophages and T cells. So it actually reducing the release of these destructive cytokines. So it can actually lead to decreased swelling, slow joint degeneration, and then fewer flare-ups and long-term joint preservation. And they modulate neurotransmitters, glutamate, which amplifies pain signals, and I mentioned that earlier. Serotonin, which it has to do with mood and pain sensitivity, and they increase endogenous opioid activity. So it enhances the body's natural ability to buffer pain. And then I would say THC, in particular, activates descending inhibitory pathways at the spinal cord to blunt those incoming pain signals before they reach the brain. CBD doesn't produce the high, and THC can also enhance the therapeutic effects of CBD, and this is where we have the entourage effect. And blood work, you might notice that when you're taking blood work, you might have reduced levels of systemic inflammatory markers. So you're looking at CRP or ESR, C-reactive protein. And then when these results come in for adult populations, I do see CRP and ESR blood work decrease. So when considering cannabis as part of an integrative treatment, right? A lot of patients are on complex regimens. They're on methotrexate, they're on corticosteroids, they're on biologics. These are powerful medications. I would say start with CBD. The CBD is a great way to start, even though it's metabolized by cytochrome P450, which is the enzyme system in the liver. You start with CBD because it doesn't produce the high, it decreases the inflammation, but you just want to make sure that you take it separately from your biologic agents or your steroids or your prescriptions, because it can elevate levels of the other drugs. It can reduce clearance, affecting efficacy. It might actually increase side effect profiles. So we always say to start low and go slow. You want to begin with a very, very low dose of CBD. And then when you have side effects, you want to make sure that we, monitor blood pressure. We monitor blood pressure. You want to make sure that you titrate slowly. Some patients will have escalated heart rate for several minutes, so patients that have arrhythmias or syncope should be monitored. Sometimes there's sedation. So if the pediatric patient is on other medications, other sleep aids, antihistamines, benzos, opiates even, you want to monitor that as well. And then I would say that if there's any cardiac issues, make sure there's cardiac clearance with the cardiologist, because it can increase the cardiac effects of amphetamines, antidepressants, beta blockers, and diuretics. And then INR levels in patients. If they're taking warfarin, for example, for whatever reason, it can affect increased risk of bleeding. So and I've talked about this ad nauseum, but I would basically say when you talk to a teenager, like we talked about Luis with cannabis overuse in the very beginning, teens managing a chronic pain and stress, cannabis can feel like a lifeline, right? It can help them sleep and dull discomfort and give anxiety, pain that's not controlled, emotional needs that are not being met. So when teens begin to rely on cannabis as their own coping tool, that's where clinicians step in, with curiosity and care. So instead of asking, why are you using this so much? We should ask, what's this helping you get through? If we reframe cannabis overuse not as defiance, but as a young person really doing their best to manage this heavy load, sometimes this is the only tool that they trust or they have. Our job is not to demand abstinence. It's to better understand the function of the substance that the substance is serving, and really gently expand the teen's toolkit so they're not just relying on cannabis alone. So change begins with safety, not ultimatums. You want to ask, what need is this meeting? Use curiosity, not control. And then I would add skills before removing supports. So before going cold turkey on stopping cannabis use, if you think that there is overuse, give the teen tools so they can start to really embrace that, and they have something to use in place of the cannabis medicine, right? We really need to move away from this all or nothing thinking. It's really about harm reduction, balance, and informed use. I think the best outcome comes when teens are not problems to fix, but they're people to support, and we need to lead with empathy and not fear tactics. So I'm almost done. How are we on time, Sang? Because I feel like I've been talking forever.
One more slide.
All right. So practical takeaways for clinicians. So I'm going to wrap up here and then just bring this all back to the clinic, the exam room, the school office, where all these conversations are already having. So whether you're a pediatrician, or maybe you're a specialist, maybe you're a school nurse or a therapist, or maybe you're a community health worker, these are some practical ways to engage with families that are navigating JIA and cannabis right now. You want to normalize the conversation, right? We can't afford to treat cannabis like the elephant in the room. If we're silent and families turn to TikTok or Reddit, not because they don't trust us, it's because they don't have that offers a safe place to talk. The key is shifting from suspicion to curiosity, right? So instead of asking, do you use cannabis? You might want to try, have you or your family considered cannabis or CBD as part of your child's care plan? Right? This subtle shift in language really opens up space for honesty, and it really signals that we're not here to judge, but we're here to partner. Secondly, I would go beyond the surface and ask why. If the teen is using cannabis, there's always a why. Is the pain not being addressed in the current care plan? Is it to manage anxiety around school and peers, or even a medical procedure? Is it helping with sleep or appetite or even social connection? Understanding the why moves us from reacting to responding. It reveals the need behind the behavior. And in that need is where the real work begins. Third, be the trusted source. Most families don't expect their provider to have all the answers, but they do hope will help them make sense of all the noise. Even if it's a 5-minute conversation about cannabis safety, that can go a long way. Number 4, push for better data. We're still operating in a pediatric evidence desert. So most clinical data on cannabis comes from adult studies or animal studies. We need child-focused research, not to promote, but to protect safety, right? This means advocating for IRBs, research networks, clinical collaboration. Your voice, especially from the front lines, can help push this work forward. And let's be clear, this is not about endorsing cannabis. Like when I hear, a lot of clinicians will say, well, cannabis legalization, does that mean you're universally endorsing cannabis? It's not. It's really about regulating and safety and education and access. It's really about refusing to leave families in the dark, because the future of integrative care is not black and white. It's a space where cannabis is neither demonized nor blindly promoted, but we evaluate very carefully and compassionately. This is harm reduction. This is good medicine.
Okay, great. Dr. Chen, thank you so much for this informative presentation. I know I've learned a lot. So I think we have time for some questions. So let's see. So can you discuss the use of cannabis for pain management in HLA-B27 arthritis and its effect on the developing brain in adolescents?
Yeah, I mean, I remember when I tested positive for HLA-B27, and we finally figured out that I had AS. It was just so heartbreaking. It was so heartbreaking, and I remember the physicians, recommending anti-inflammatories. Right, that's the first thing. It's like, we need to get this inflammation down. We need to get your flare-ups down, and cannabinoids can be great for getting that inflammation down. And inflammation is the root cause of the pain. Right, when you have chronic inflammation, that's what causes the pain discomfort. That's what causes those joints to change in structure eventually.
Mhm.
So I would say CBD is great to start as an anti-inflammatory, because you want to be careful of the THC in developing brain, like I mentioned in my lecture.
Thank you. How often is it recommended to perform liver function testing in juvenile patients receiving cannabinoid treatment?
I would say regular liver function tests with your normal blood work. A lot of the juvenile patients are already getting regular blood tests because they're on, biologics, or they're on other medications. So I would say every quarter. If you're going to the doctor every quarter, every 6 months, it would be good to just have that blood work done, especially if you're taking it with other meds.
Great, thank you. How can we effectively collaborate to increase patient access and affordability of medical cannabis for families through allowing the integration of medical cannabis in group health benefits?
Oh my God, that's $1 million question. That's the $1 million question right there. We've all been waiting for that. I would say, especially in New York, I know we can home grow and make our own medicine. I think it's super important to lobby for medical cannabis being covered in group health benefits. It should be covered just like dental and vision. I know a lot of families who have health savings account and flexible savings accounts. They use cannabis medicine and they use it as a write-off. The affordability of medical cannabis sometimes can be onerous for families, as does other complementary medicines. Like in my story earlier, Avi went to massage therapy and physical therapy. He had nutritionist. Those are all out-of-pocket costs, just like
Yeah.
medical cannabis.
Right. Okay, and we have one more question. Is cannabis use recommended for any age with respect to migraines?
Migraines. So it depends on, how debilitating the migraines are, right? Sometimes patients with migraines, if they add CBD, they might notice that they recover from the migraine a lot faster. Like if it normally takes you like 48 hours to recover from a massive migraine, they might be able to bounce back within half a day. They might notice that the decrease in inflammation, again, here we go with inflammation of the migraine, and what triggers it turns the volume down on the migraine intensity and frequency. So I do recommend, again, starting with a CBD-based product. If you're an adult, obviously with migraines, you could add THC, but too much THC can cause rebound headaches, rebound migraines. So you do want to be careful. Less is more.
Okay. So I think that is it for questions. Dr. Chen, thank you once again for this wonderful presentation. So I just have a couple of closing remarks. So as we conclude, we'd like to remind you that the replay of today's session, along with the presentation slides, will be available on our YouTube channel immediately after the webinar is done. And we encourage you to sign up for our newsletter. That's the link should be going up. And you can also visit cannabis.ny.gov for more information on our medical cannabis program. And we will be, the post-webinar survey should also have a link. So please fill that out when you have a moment so we could improve and make our webinars even better. And please stay tuned for information on our next webinar series. And thank you so much for joining us today. And we'll see you next time.